Will discuss about the answers of the MCQs along with their explanation of gastrointestinal and respiratory pharmacology. First is drugs used for the treatment of gastric ulcer due to H. pylori is, and the options are anticholinergics, carbenoxolone sodium, bismuth subcitrate, and corticosteroids. Now, H. pylori, you all know that H. pylori is responsible for recurrent peptic ulcer, and that's why antimicrobial therapy, true antimicrobial agent along with the 1-acid suppressant, mainly the PPI, is used for the treatment of peptic ulcer due to H. pylori. Many a times, the colloidal bismuth subcitrate, which is an ulcer healing agent, is also added as a quadruple therapy. So here the answer is colloidal bismuth subcitrate. Anticholinergics are of no use. Corticosteroid and carbenoxolone sodium are also the out of the question. Okay. Which one of the following is not an antacid? And these are magnesium sulfate, megaltrate, magnesium carbonate, and magnesium phosphate. Now, the magnesiums, aluminum, and carbonate salts, they are commonly used as a non-systemic antacid for the symptomatic relief of peptic ulcer. Okay. Magnesium carbonate, magnesium phosphate, megaltrate, these are commonly used. But magnesium sulfate, it is an agent which is primarily used by the intravenous route for the treatment of eclampsia. It is not used for this purpose. Again, magnesium sulfate is a classical example in which if it is used by the different route, it is having a different therapeutic indication. Preferred agent for the prevention of NSAIDs induced ulcer is, now NSAIDs, these are the non-steroidal anti-inflammatory drugs. They are having analgesic and anti-inflammatory action because of the prostaglandin synthesis inhibition, and these prostaglandins, they are having a protective role in the gastrointestinal mucosa. Okay, and that's why if you are giving the prostaglandin analogs, they can prevent the peptic ulcer due to NSAIDs, and actually this is the only indication for the prostaglandin analogs, is that when you require an NSAID for a very long period of the time to prevent the development of the occurrence of peptic ulcer, prostaglandin analogs are used. So here out of all the options, the misoprostol, which is a prostaglandin analog, it is the correct answer. Fine. But suppose if the question is that which agent will you use for the treatment of NSAIDs induced ulcer, once the ulcer is already occurred, then you require a gastric acid suppression, and that's why H2 antagonist, or even better, the proton pump inhibitor should be the correct answer. Following are the advantages of ranitidine or cimetidine except action on H2 blockers, action on H2 receptors. Both of these two are acting on the H2 receptors, given orally, both are given orally. Used with proton pump blockers, both of these two agents can be used along with proton pump blocker. And anti-androgenic action. Okay, now the cimetidine is having an anti-androgenic action, and this is the biggest limitation. In addition to other, ranitidine is preferred over cimetidine because this anti-androgenic action is not seen with ranitidine. So the answer is anti-androgenic action. Antacids that typically causes diarrhea is, we have discussed that magnesium, aluminum, and calcium salts, they are used for the symptomatic relief in case of non-ulcer dyspepsia and peptic ulcer. Magnesium is typically responsible for the diarrhea while the aluminum is responsible for the constipation. So here the answer is magnesium hydroxide, and that is why many a times the magnesium and the aluminum salts are combined to nullify the adverse effects of each other. Pharmacological actions needed for the healing of the peptic ulcer of sucralfate is affected by, sucralfate is a ulcer healing agents, and it acts by creating a layer over the ulcer, it converts into the gel-like consistency which protects the ulcer, cover the ulcer. But this is possible only when the pH is less than 5, means when the pH is acidic. Now if you give the antacid, this conversion is not possible, hence the pharmacological action is not possible. So the answer is antacids. These two agents should not be given together. Which of the following is not an adverse effect of cimetidine? The options are impotence, atrophic gastritis, then gynecomastia and galactorrhea. I already told you that cimetidine is having anti-androgenic action, and because of this impotence, gynecomastia and galactorrhea can occur, but atrophic gastritis will not occur, and so the answer is atrophic gastritis. Primary role of the antacid in peptic ulcer. The options are symptomatic relief, H. pylori eradication, ulcer healing, and all of the above. Now you all know that antacids, they are primarily used for the symptomatic relief, but why not for the ulcer healing? The reason is that for healing of the ulcer you require a gastric acid suppression for a long period of the time, which is not possible with the antacids. That's why it is not used for that purpose. And there is no question about the H. pylori eradication, because for that you require antimicrobial agents. So here the answer is symptomatic relief. Drug not used in the treatment of H. pylori infection is cisapride, metronidazole, clarithromycin and omeprazole. I already told that the antimicrobial agents along with the gastric acid suppressants, mainly the proton pump inhibitors, are used for the treatment of H. pylori infection. So metronidazole and clarithromycin, these are antimicrobials, they are used. Omeprazole, it is also used, but cisapride, it is a prokinetic agent, it is not used for this purpose. So the answer is cisapride. Melanosis coli is caused by, the options are bisacodyl, senna, magnesium sulfate and lactulose. Now senna is a stimulant purgative. When it is used for a longer period of the time, it will causes the brown pigmentation of the colon, which is known as a melanosis coli, and so the answer is senna. Which of the following is not a prokinetic agent? Cisapride, yes, it is a prokinetic agent. Motilide, it acts on the motilin receptor and increases the gastrointestinal motility. So it is also a prokinetic agent. Metoclopramide, it is also a prokinetic agent. But yes, diphenoxymethane, it is not a prokinetic agent. Now, just for your information, not related to this MCQ, what do you mean by prokinetic agent? The agent which increases the gastrointestinal motility is known as a prokinetic agent. This is possible by following mechanisms. Either you increase the tone of the lower esophageal sphincter, increase the contraction of fundus and the body of the stomach, relaxes the lower part of the stomach, increases the peristalsis of the duodenum, small intestine and large intestine. These are the characteristic action of prokinetic agent. Not true about composition of ORS. ORS means oral rehydration salt solution. In this, various iron salts along with the glucose is added. So the sodium chloride, yes, potassium chloride, yes, trisodium citrate and glucose. So sodium bicarbonate is not in the composition of ORS. So the answer is sodium bicarbonate. Glucose is added to the ORS. You have seen that in the previous question, glucose is added to the ORS. What is the role? Is it only for the energy purpose or something else? And the answer is something else, and that is to facilitate the absorption of the sodium. One of the mechanism for the sodium is glucose facilitates the absorption of the sodium. So the answer is D, increased absorption of sodium. True about metoclopramide is, so metoclopramide we have already discussed, it is a prokinetic agent, but it will not inhibit the cholinergic smooth muscle stimulation. No. It decreases sphincter, lower esophageal sphincter. No. It stimulates D2 receptor. No, actually it is an antagonist of D2 receptor. Enhances the gastrointestinal motility. Yes, because it is the prokinetic agents. So the correct answer is D. Which of the following drug cannot be given by the route shown in the picture? Here the meter dose inhaler, so it is given by the inhalational route. Salbutamol, it is given by the meter dose inhaler. It is the drug of choice for acute headache of bronchial asthma. Cromolyn sodium, budesonide, it is an inhalational steroid, obviously given by inhalational route, and montelukast. So now you are having doubt about chromoglycat and montelukast. Chromoglycat is a mast cell stabilizer and it is given by the inhalational route, while the montelukast is a leukotriene antagonist. It is given as a tablet form. Okay. So the answer is montelukast. Mechanism of action of theophylline in bronchial asthma is phosphodiesterase inhibitor. Then beta 2 agonism, obviously not. Beta 2 agonists are salbutamol, salmeterol, terbutaline, bambuterol. Then anticholinergic, no, it is also not there. And inhibition of the mucociliary clearance, it is actually contraindicated in case of such type of action in bronchial asthma. So if you go by the elimination, you can come to the answer, that is phosphodiesterase 4 inhibition. And ideally you should know the correct answer without elimination also. There are multiple mechanisms of the theophylline as a bronchodilator, and one of the mechanism is phosphodiesterase 4 inhibition. The following drug is not useful in acute attack of asthma. There is salbutamol, cromolyn sodium, hydrocortisone and theophylline. Salbutamol we have already discussed. It is the drug of choice, fastest acting bronchodilator to terminate the acute attack of bronchial asthma. But hydrocortisone, even though it is a slower acting as compared to the salbutamol, but hydrocortisone hemisuccinate 100 mg intravenously, it is used in the treatment of status asthmaticus. Same way the theophylline can be used, but cromolyn sodium is a mast cell stabilizer. It means it stabilizes the mast cell. It inhibits the release of the inflammatory mediators, which is responsible for the bronchospasm and the acute attack. But once the acute attack is occurred, then there is a no role of cromolyn sodium. It is only used for the preventive purpose in seasonal asthma. So the answer is cromolyn sodium. Common adverse effects seen with the use of the inhalational steroid, that is oral candidiasis, Cushing syndrome, decreased ACTH and hypertension. Now here one thing should be clear, that here the question about only the inhalational steroid related adverse effect asked, because you all know that the systemic steroid exposure is having many advantages as well as disadvantages like hypertension, diabetes, Cushing syndrome and many more. But the topically, because through the inhalational route if you are taking, then the decreased oral immunity, and that's why the oral candidiasis and the hoarseness of voice, these are the most common adverse effects. So here the answer is oral candidiasis. Most common dose related side effect of salbutamol. Salbutamol is a beta 2 agonist, and the beta 2 receptors that are present on the skeletal muscle spindle, and that's why it is responsible for the characteristics tremor. Even though the palpitation is there with the salbutamol because of the somewhat beta 1 stimulation on the heart, but still the most common out of all these is the tremor. Directly acting cough suppressant is, there are two type of the cough suppressants. One is the acting through the opioid, and second is the non-opioid. They are used for the dry cough, and the opioid is codeine, and the non-opioid is dextromethorphan. Okay, acetyl N-acetylcysteine and the bromhexine. These are the mucokinetic agents. Carbapenem is out of the question because it is an antimicrobial. So the correct answer is dextromethorphan. So this is all about the answers of the MCQs of the respiratory and gastrointestinal pharmacology. Please write your comment in the comment box. Thank you very much.